The title of my talk will be Microbial Keratitis, Watch for Telltale Clinical Signs. But before I begin talking about, one of the messages that I want to give you is taking a careful and complete clinical history, and performing thorough clinical examination are two distinguishing characteristics of a master clinician. Premature judgment and failure to continue considering reasonable alternatives after an initial diagnosis is made are two most common diagnostic errors. And we have seen that in corneal ulcers, both of these factors account for missed diagnosis of common diseases. The objective of my talk will be to share with you why is it essential not to get stuck to initial diagnosis, and how attention to history and clinical examination helps in etiological diagnosis of corneal ulcer. And I'll be showing you cases to substantiate this point. The first case is a 29-year-old male with the complaints of redness, pain, watering and diminution of vision of 1 month duration. He denied any history of trauma, any similar episodes in past, no significant systemic history, and no history of similar episodes in past. The corneal picture was as shown on this slide, with a localized area of corneal edema extending the full thickness, and the surrounding cornea was clear. The patient was evaluated earlier by local ophthalmologist who started treatment with fortified ceftazidime and fortified gentamicin, both given 1 hourly, and atropine 3 times per day. On the day of presentation, as I showed you the clinical picture, and the visual acuity was 20/60. How are you going to manage this patient? I am sure that the first diagnosis that will come to your mind in a patient of localized corneal edema, which is a disciform shape, will be the herpes simplex virus stromal keratitis. We thought the same, and the patient was started treatment with prednisolone acetate 6 times per day, acyclovir tablet 400 mg 5 times per day with home atropine 3 times per day. In 2 weeks, the edema reduced and the visual acuity improved to 20/40. Patient was feeling comfortable. In another 2 weeks, the clinical picture was as shown here, with most of the edema disappeared. There are keratic precipitates or pigments on endothelium that could be easily seen. I am sure you must be thinking that this patient is doing well and would have liked to continue the treatment. But when we evaluated, we focused on this area where the epithelial defect is persisting, and there are some lesions which were looking suspicious. And therefore, we did corneal scraping, and we found multiple acid-fast bacilli on acid-fast staining, which on culture grew Mycobacterium species. Let us look at second case. A 32-year male from West Bengal came with complaints of pain, redness and blurring of vision of 5 months duration. There was no other significant history. If you look at this history, what is very unique in this history? And I'm sure you will all agree that why somebody is suffering with the symptoms for past 5 months. The patient was treated before coming to us with acyclovir eye ointment 5 times per day at home atropine and carboxymethyl cellulose, and had a clinical picture which had a geographical epithelial defect with underlying stromal infiltrate. Are we correct that this patient is suffering with HSV keratitis, or should we revise the diagnosis? The pointer for revising the diagnosis was why this patient has not responded to acyclovir treatment for 3 weeks, and why is he suffering for past 5 months. And that gave us a clue that we probably are dealing with a slowly progressive disease. We did corneal scraping. Unfortunately, the corneal scraping turned out to be negative. And therefore, we decided that since it does not appear to be HSV, let us stop all the drugs and repeat scrape after 2 days. In 2 days, when the patient returned back, patient was symptomatically better. And if you look at this lesion, there is some clearing of infiltrate in this area compared to what the patient presented. What is leading this kind of a change when we have stopped all the drug? And still we could not get an answer, therefore decided to do corneal scraping, which revealed gram-positive beaded curved bacilli, which on acid-fast staining were identified as AFB, and in 3 days the culture grew Mycobacterium species, which was susceptible to Cipro and amikacin. We started amikacin eye drop and patient started responding. So we were able to make the diagnosis. After 2 weeks, patient left back to West Bengal and on teleconsult informed us in 2 months that the patient has resolved keratitis. Let us look at this patient who presented to us again with the history of 4 weeks duration, had a localized circumscribed stromal edema with keratic precipitates, no epithelial defect. How will you manage this patient? I am sure again, like the first patient that I showed you, we will start the patient on corticosteroid therapy. We did the same on day 11. The patient had a picture as shown on this slide. But by day 31, on corticosteroid therapy, the patient showed a frank ring-shaped infiltrate with hypopion, which on corneal scraping turned out to be acanthamoeba. All of these patients had the common diagnosis of herpes simplex keratitis. But a careful clinical examination and attention to history and not getting stuck to your initial diagnosis helped us to arrive at a definitive diagnosis and help the patient. So in this patient, what did we miss? Why we continued this patient on corticosteroid therapy? We probably missed that a typical HSV keratitis patient treated at this stage would have shown resolution of infiltrate without producing an epithelial defect. On day 11, if we would have paid attention to this epithelial defect, we probably would have done appropriate investigation and would have been successful in an early diagnosis. Let us look at these 3 different images. Again, the clinical picture mimics that of herpes simplex virus keratitis. But all of these patients finally turned out to be caused by microsporidia, a relatively uncommon organism. In earlier part of our journey toward microsporidia, all of these cases were identified on histopathology examination, but as our knowledge improved, we are able to diagnose these cases on corneal scraping. It not only presents as herpes simplex virus keratitis, it has a very long duration of history. Many of the patients have symptoms for years together. But the clinical picture can also mimic any other case of necrotizing stromal keratitis or stromal keratitis and may even present with desmetocele and corneal perforation. To conclude, what I wanted to discuss and share with you is that a detailed history and a good clinical examination are extremely valuable. We should not lose sight of those skills that were taught to us when we started our journey in medicine. The second message I wanted to discuss with you is one should not hesitate to revise the diagnosis if the clinical picture or the response to initial treatment is not appropriate. The third message is that microbiology will give you or will be more valuable if you make some presumptive diagnosis. We should not just use microbiology in a haphazard manner. If you have not considered AFB, you will not be doing acid fast staining, and that's where you are likely to miss AFB. I like to end my talk by this wonderful quote: uncommon presentations of common diseases are more frequent than common presentations of uncommon diseases. Thank you very much for your kind attention.